Good morning, everyone. Thank you all for joining. I'm Jessica Wharton. I'm the waiver manager here at the Bureau of Developmental Services. And joining us today, we also have Nancy Rollins. Everyone. Okay, and then on the line as well from A&M, we have Drew Smith and Alicia Ortiz. They're here to help us facilitate the meeting and assist in supporting our discussions as a group. So let's jump into the presentation.
Sorry, all it takes just a second for my screen to move to full window.
Okay, so for today's meeting, once again, thank you all for joining. Our goals for today's meeting, we're going to, again, confirm our work group participation expectations. We're going to increase the group's shared understanding of service characteristics. Also, for discussion today, we'd like to explore workforce opportunities. And we'd also like to set a baseline understanding on existing work to date and our next steps. And just a reminder to everyone, this waiver work group is open to the public. Those of you joining us in the public who are not on the waiver work group are able to listen to our discussions, but are not able to ask questions or participate in the discussions occurring between the group members. This structure is set up to ensure that BDS can engage in a diverse group of stakeholders in substantive dialogue, while also providing transparency and general updates to the public. But if you do have a question, please feel free to forward those questions to BDS Waiver Structure Work Group at dhs.nh.gov, and we will respond to them as soon as possible. Also today, we're not going to do formal introductions of our work group members. What I would ask though is if you raise your hand or want to share, to please just announce yourself, especially since a lot of folks have the slim panel on the side while we're presenting, just to let everyone know who's speaking. You can go ahead to the next slide, please, Lisa. Okay, so our agenda for today. First, we want to review and discuss our service mapping responses, our assignment from October. We had a lot of great input that we received, and we want to dive right into that. And then we'd also like to take some time and discuss provider requirements around DSP training, different opportunities, really have a deep discussion on what those opportunities might be, as well as an environmental scan. And then before we finish the meeting, we'll talk about next steps and our assignment for the month of November and discuss any questions that the group might have about the presentation or our November assignment. Go ahead to the next slide, please. All right, so we're going to jump right into our service mapping review and discussion. So the feedback that came in was awesome. It was really great to see what everybody's thoughts are based on our current waiver and our current services that were defined. And what we've done is pulled out a few common pieces of feedback, common questions here. And I'll go over them, but really love down below, you'll see there are some of the questions highlighted here. So if you recognize this as one of your questions, or if you had any other thoughts or comments that you wanted to share about the various services or comments that you provided, please raise your hand and we'll start reviewing. So for the themes that we noted, first was a request for clarification on the different services, the service definition, some about limits and various aspects of what's written into the waiver currently, clarifying questions about eligibility, not so much for DD services, but specific to the service itself, questions, how to access, things like that, what caps might be in place. A huge interest and support for telehealth. Many folks expressed an interest in expanding telehealth or the importance for continuing telehealth on as a service for some, an option for some services. There were concerns shared about capacity and training as well. Some respondents noted that capacity limitations are barriers currently to implementing some services, and we'd really love to dive into that discussion. As we noted before, the latter part of this presentation, we're hoping to have a discussion as well around that. And then We also have individuals interested in further defining services, either currently or how we want to expand them and define them in the future. Some respondents noted that there were services that seemed to have an overlap and asked for maybe clarification what the distinction was for those services. And others questioned the unique value of some of these distinct services. Could they be combined with another? Do they need to be their own separate service, for example? And additionally, some services were flagged as needing more definition as well. And I do have to say this is really great feedback as well, especially for the current waiver standpoint and for the work that we're doing, because as we build out some of our information for the currently approved DD waiver, we'll make sure to include some of that clarification on current services as well, especially around the newer services. So down below in the thought bubbles, you'll see some of the questions that were provided. Would anybody like to kick off the discussion or share some of their observations or their insight around the services? Let's see, I'm looking for some hands. Okay, well, one of the observations that I noted in going through the services, and this may be on a later slide, so Alicia, don't kill me if I'm going ahead too much, but there were some responses around the potentially, possibly breaking out certain components of different services. There were several comments throughout many of the services saying, gee, what would this look like if there were different levels, for example? Maybe we think it's something that could or should be on both waivers, but having different levels of access or levels of, rates of service, things along those lines might be really helpful. Did anybody have a comment similar to that that'd like to share possibly what they were thinking and how that could lead to more independence and what that might look like, based on how you were envisioning it as you went through the homework?
Hi, Jessica. This is Jen Cordero from Beckett. So I can speak to that because we did include a comment under ResHab. We provide a couple different models of shared living. So one is more of a clinical medical model where we have some embedded staffing hours and clinical support. So I think that's where we were coming from, just sort of making sure if this feeds into the rate structure, that it's sort of a separate defined service.
Okay. That's great. And I believe I saw a few comments specific to residential as well, actually, about if it were offered, and I hope I'm capturing this correctly, but if it were offered in both waivers, possibly enhanced family care in both, but maybe a 24/7 staff residential model and possibly ITS services on a comprehensive waiver. Was anybody else looking? And again, I'm summarizing multiple respondents as well, so please feel free to share anybody else who might have felt that same way. I'm seeing some head nods as well.
This is Sarah Menard from Crutchet Mountain. I think I put something similar to what Jen mentioned under residential, trying to clarify that, residential isn't an assumption that means congregate setting. If we can break that out into more of a continuum of, home life supports all the way from, supports in the family home to ITS level services and everything in between, including shared living, or, I think I also mentioned kind of more medical model. There's, and I think we differentiate kind of within our programs already just in kind of program design, but it's not reflected in rate. And it's not really reflected in how we define it within the waiver. So I think being more specific about what do we mean by residential, and maybe changing some name, maybe not calling it all residential, because I think there's a big continuum of living situations that are currently kind of under that umbrella term.
Yeah, that's great insight as well. I noted too, actually, does anybody else want to share while we're on residential?
I think I was just trying to understand, and I might have been one of the, can an individual be on 2 waivers folks, just trying to understand the fluidity and how it would work. And it might be way too mechanical for our conversations right now. I guess my concern when we talk about limiting access and people changing on a continuum of care is gets really in the weeds right now. But we have 10 million roughly pending in PAs that aren't approved at the bureau level right now. And I just worry about all of the transactions that have to happen for people to move around in service levels and waivers. And again, that might be too far in the weeds right now, but I can't help but think of that when I look at, where we are right now.
Yeah, I don't think it's too far, Becky. It's something for us to capture definitely in terms of what does it look like transitioning between one waiver to the next? What's that process flow? What's the anticipated turnaround time? I think it's a great comment for us to capture and make sure it's part of our discussions as our group continues on.
Can I just add a quick comment to that, Jess? So Becky, I 100% agree. So under Medicaid law, right, we can't have somebody on dual 1915C waivers. Right. And so what's really important as we think about this conversation is what are the upper bounds of access to services in either one, specifically the supports waiver, so that somebody doesn't have to trigger that threshold to go into a comp waiver every time something changes. Let's build as much flexibility in that waiver structure, and as we think about units and capacity, and then really leave that shift, because it is going to be a big shift, right, to go from one waiver to the other. Hopefully we can build in the mechanics so that it's a little bit more of an easy step, because I hear your message about PAs and using IT to help in that process and make it a little bit more streamlined. But as much as we can, let's build out the infrastructure and the supports waiver to support people's lives changing, right? So it doesn't always trigger having to go into a new waiver structure, but we have enough flexibility in the supports waiver itself. So I think it's a really important comment. I don't think it's at all too early for us to be thinking about that. And I think we need to keep coming back to it as these conversations continue.
Does anyone else want to share regarding residential services?
Jessica, this is Jen from New Hampshire Family Voices. I just want to kind of echo making sure we're really clear on what the definitions are. So adding to what Sarah said about residential can mean multiple things, because I know when I touched base with some other families about this, they were like, wait, what does that mean? And what does it look like? Because we as families don't always use the term they're in a residential setting when they're at home. So really thinking about that and how we message that. My brain was going we have the communication committee and thinking about how are we going to message this out so that it's understood and that it's really clear, because I know a lot of families, the challenge right now is and going back to service training, if it doesn't specifically say in a waiver, yes, you can do this, we're told no, even though it doesn't say no, you can't. So thinking about those kind of things, because that's a huge challenge for families. So getting really clear on what things mean and what it looks like and putting it out there.
Okay, definitely.
Can I just add one thing? This is Renee Fisher from Easter Seals. It's interesting to hear all of the feedback around this, because I do think that the clarification needs to happen, but we've been so used to just sort of bundling everything in under one thing. And so we've always said, oh, residential is residential, and it could mean 25 different ways of serving someone. And so, is the thought process with this going to be that it will be that detail oriented, so that, an ITS home is going to be different than enhanced family care, and it's not going to kind of all fall under the same thing? Is that the goal? Or is the goal to have the flexibility and then create the program and the proposal within a flexible residential waiver? Do you know what I mean? It's interesting just to listen to the comments, because we're just all so used to saying residential is residential, and then we make it what it is in serving individuals. And so is the goal going to be to make it that I'm trying to think of the word, but just that detail oriented. So there will be all of those different levels. And then is that the goal to then have that feed into the rate structure?
Yeah, so I think right now, in looking at what we currently have, and I know sometimes it is kind of, it's a lot to think about what are the options, what could be. And part of what our assignment for this month will be is to look at some peer states as well, not to skip ahead too much, and see how others are approaching this. You know, is it broken out? What pieces are broken out? Is it broken out specifically by residential settings, or are different components of what we consider residential broken out? And really before us to take a look at all of that and see what are we thinking makes the most sense for individuals in New Hampshire, and what are those opportunities? And Drew, I don't know if you have any additional thoughts on that as well.
Yeah, I think it's you're right on, Jess, and Renee, thanks for the question. I mean, I think from a rate setting perspective, right, the more detail that the rate setters can have to build out a service, the more that we ensure the cost structures of that service are being covered. And so part of the challenge with blending services under one definition is there are probably some services that are definitely covering costs, and there are some services where things are really tight or are not covering costs, right? And so the more definition that we can get there, the more we can ensure that the cost structures of each of those unique services are really captured. That doesn't necessarily mean, I mean, going to more detail doesn't necessarily mean the loss of flexibility though, right? So as we think about residential, and I know we're focusing a lot on residential in this conversation, but if we think about breaking residential into the types of residential services that are happening so we can build the right rates, then really it's about how is the service planning and the case management structure making sure that people understand what each of those services are. I think getting back to Jen's comment about how are we communicating that to families so that families go into service meetings understanding what the options are and what the right service for them is. And then as providers, we know that the cost of that service, if it gets put onto a plan, if it's a service that you're going to provide, is covered. I think there's a lot of good things about having a lot of services fall under one bucket, but I do think that that's part of what is probably challenging the system now is when we talk about rate inadequacies, I think part of that is driven by so many things being covered under so few buckets. And so I think the more we can break that out, the more we can just ensure we can get staffing ratios in a more targeted way to make sure that, you know, we're thinking about the skill sets of DSPs and different services as well, and that the wages that are associated with that are unique to that service. So, yeah, I think it's a mix of what you stated. I think it's how do we build the detail around the services and the definition to feed into the rates, but then how do we really make sure that the case management structure, the plan development structure remains flexible within that.
So I think it feels a little bit like, I guess I'm trying to make an observation that right now we start from the bottom and build up. So when we work with a family and we talk about, you know, what is residential, you know, all of the current things we're talking about, all the residential options are on the table. So we work with a family and the case manager, resource coordinator works on person-centered planning, works on developing a service agreement, and builds what that is. And currently in our current system, when you get to the billing piece, that is completely in an administrative function that's not, I don't want to say not transparent to families, but families wouldn't even in general care because of how our current structure is. I'm not trying to say we're keeping anything from families, but because of how our current structure is, families wouldn't get into that or care. At the end of the day, on the business side, we say, this is what they built, this is what the budget is, and we need to make our current billing mechanism work, which is why I think that when you've looked at budgets, you know, at the state level, you can see that we're billing RPC level 7, and you have no idea unless you dive into a service agreement what that actually is. Because I think to Jen and Renee and other people's points, it's going to look vastly in RPC level 7. You can pull 20 of them statewide, and you're going to get 20 very, very different looking programs. And I guess I'm still trying to understand the goal, because I understand, you know, it seems like you want to be able to look from a statistical, from a Concord level, you know, top down, be able to look and see what everybody in the state is getting. And that's okay if that's part of our end goal here. I'm just trying to understand that because it's not going to change anything in how we present to families, deliver to families, and work on what and again, we're just talking residential right now. If they need some residential service, we present a continuum that shows independent living all the way through community residences and look at residential as a continuum, and that's what we present to families. They could care less. In my experience, they could care less about RPC level 7, level 6, level 5. It's truly a billing mechanism. And if you're just trying to get more correlation to data, that feels like what the end game of this is going to be, is that you'll be able to look at data and understand what's already being done in New Hampshire, but it's really not going to be done differently. Is that an accurate observation?
I mean, somewhat.
Oh, go ahead, Jess. Yeah.
Oh, I was just going to say, to a certain extent, and I think that person-centered planning, we want to stay the same. We really don't want individuals or families to be trying to factor in rates and levels and things like that when they're saying, hey, these are the services that will allow me to live my life the most independently and provide me with the level of support that I am looking to access right now. But also one of the really common themes, and Drew and Alicia, if you have more insight on this, let me know. One of the common feedback or pieces of feedback we received in this exercise, and as well as just in general, is around rates, and what does that mean when there are so many services included within one service? How can you ensure that a rate can capture what's being provided for somebody who's maybe, right now, if we talk RPC levels, and I apologize for anyone out there who's maybe in RPC level 1, level 2, what if it does fit evenly in? What if it doesn't? But then we're all the way up to 7 when we're trying to capture that. This data would allow us to hopefully provide some information to the rate setting group as well that would help them to build those rates out, especially if we were able to define certain aspects or components of each service, or even, as some folks mentioned, gee, what if we were to separate personal care, for example, or intensive treatment services? Drew, go ahead. I'm sorry, I didn't mean to.
No, I think that was really well said. I mean, so Becky, to more directly answer your question, I don't think that this is all about a correlative function within the data, right? And so I think there is some of that, right? We want to make sure that what people say they need, they're having access to. I don't think that that's the concern now, but I think what we've heard, and Nancy, I'll give you some space here as well, is that, to your point, right, there's might be 20 people accessing level 7 in 20 different ways. And while that looks very unique to them, I think what we've also heard is that's not necessarily the same across the state of access to those same services. So I think the way that you're looking at continuum of care is fantastic. I think what we've also heard is some families don't always feel like there's equitable structures in place to access services across the state. And so how do we build, again, not trying to say that this is going to change everything that you all are doing around residential, your area agency, but instead give kind of an equal playing field to what the services are, what the services mean, so that as people are building their service plans and their service agreements, that they are using that kind of base common structure. And so we don't want to take the flexibility out of that, but we also want to add some construct around it so that we can really get to more of a statewide approach to services. So that again, as we go to this new rate schedule to make sure the costs are covered, we know that we're doing that in a way that's going to work for everybody. And again, I agree with you. I mean, budgets should not be the driver for families, and they often aren't, and they shouldn't be. But we also want to make sure that providers, right, that there's adequacy there to make sure that you guys can continue to have the infrastructure to support these services. And so as we build this out, and as we look at the cost structures and we look at the rate structures themselves to fund these services, we do want to be mindful of, how do families engage with the system, but also how do we ensure an adequate provider network to provide the services that families want. And so it really is both sides of it. But Nancy, I mean, from the state's perspective, if there's anything else to add.
No, Joe, I think that captures it. I mean, while we're in this exercise with waivers, excuse me, clarifying the language relative to what is the service, it is really going to get played out in the rate setting in terms of making sure that we have equity in those rates, so that their true costs are getting covered when we're defining these services. So that's really the important piece here as we go through this exercise.
Thank you, Nancy. Andrew. So I would like to pause some of the thought bubble questions down here we've touched upon, but they do represent some of the more frequent questions. So there was a question about what is considered an acute care setting for HCBS. The way we've defined it in our waiver is an acute care hospital. Will units be capped? That is something as we're going through the different services available and as we're building this out, we can talk about that as a group to see if there, you know, if we're thinking that there is a reason or a value in capping a service, and we can make recommendations on that. Will telehealth be covered? Same thing. We can look at that. What are the options out there? How can we utilize telehealth to really, you know, enhance someone's level of independence while ensuring still that they're not isolated and that they're receiving community services or services within their community, excuse me. Okay, I think we've touched upon most of the questions. Please stop me though if anybody sees one that's kind of a burning question that I didn't cover. If not, we can go ahead to the next slide. Thank you. So this is actually the result of the homework, and I'm glad that we were able to engage in a little conversation before we saw it. So here on the left, you'll see the services that are currently in our waiver and how the group as a whole responded with the key in the upper right-hand corner. The majority of the services were listed as keep without a change, and service coordination was listed as keep with change. I believe it was about a 50-50 split. And then community participation services was a keep with change as well. And then on the right-hand side of this slide, we'll see which waiver the group felt each service would fall within. So as we continue discussion, I know that we were talking and focusing quite a bit on residential before, but as we went through the responses and the comments, there were actually several services that folks mentioned tiering or maybe including in different capacities on each waiver. Service coordination, as we see on the left-hand side, was one that was noted as keep a change. There were some comments specific to respite potentially breaking out in, you know, depending on whether an individual wanted to access respite in a staff home or in the community. There were conversations around different tiers within community integration services, SEP, sorry, I don't mean to look away from the screen, and non-medical transportation as well. So would anybody like to share any thoughts, especially looking here at what the group as a whole felt about the various or the other services currently available on the waiver?
I think in terms of community participation services, probably we all agree that the flexibility that has been offered in Appendix K has been really, really helpful in really creating a better quality life for individuals rather than have them just being participatory in, you know, a day program, if you will. I think that, you know, just being able to maybe, you know, do activities in the community when it makes sense, being able to bill for activities that could be done in the that are being done in the home. So I think, you know, I'm not going to speak for everyone, but at least for our, you know, our feedback on that has been, it's been really, really nice to have the flexibility, and we've seen and really, you know, better quality in those services for individuals because of that flexibility.
And so for the flexibility, is this regarding more services, community participation services, I should say, happening within the home or via telehealth modalities?
A little bit of all of that, because, you know, we've all had success. Well, we've had success with some of the Zoom activities that we had done, and being able for, you know, for people to connect that way, especially during COVID. But again, just more, it just allows for more person-centered schedule when there's flexibility in it, because it doesn't make sense for a lot of our individuals to go in the morning at 9 in the morning and then come back at 3 o'clock in the afternoon with not a lot of quality in there, but you got to keep them out in the community. So, you know, it's difficult. We talk about people not having money and not having, what are they doing within that 6 hours of the day every day? And a lot of people have medical needs, and, they need to be able to go home. And with the 507s being the way they were, I mean, you could get it written into the service agreement, and I get that, but just being able to be flexible and fluid with that schedule and being able to still capture revenue while you're doing the different activities has been really, really, really helpful.
Yeah,
And echo what Renee is saying as well. This is Michelle from Living Innovations and PPN. The flexibility is provided not just by the Appendix K, but by the BDS guidances, because some of those things didn't end up in the Appendix A. So keeping those in mind, and just it's more of an organic way to provide more person-centered services that we have found to work really, really well. And also in light of the staffing crisis that is nationwide, we are simply unable to provide traditional day program 9 to 3 services with staffing anymore. So keeping that in mind as well, I think, is really important here.
I would agree with everything that's been said. And I think Sandy Hunt, at some meeting in the last year or so, we had this conversation a little bit, and I don't know if it's possible within CMS guidelines, but we talked about the difference between defining that 80% community versus 80% of that person's community. Like, what would our lives look like if we were to say, what does my community look like? Wouldn't look like, if I wasn't working, it wouldn't look like going out and just being out of my house, as Michelle, I think, just said, from 9 to 3. That just isn't what my day looks like. So I think, anything we can do to really, I don't mind the accountability. I don't mind, obviously we have the heightened scrutiny issue, and we need all that accountability to get people out, but out into what their real life should look like. And the 80-20 and being out in the community, I agree. It's looked amazingly better during COVID due to both the Zoom classes, a little bit of congregate settings, and just having, and again, because of staffing, but I would hate to see us as a system slide backwards only because of staffing. I would really like to, hang it on the quality of services. And I've heard people all over the board here express that the quality of services has been so much better during COVID, which is really ironic.
Hi, this is Deborah DeSenza from Farmsteads. I'd like to suggest that the name be changed from Community Participation Services to something along the lines of meaningful life activities, because as we've been saying, it doesn't have to take place at the local mall or wherever out in the community. It may take place in the person's home. It may take place via Zoom. There's a million places it can take place. And being meaningful and being the person's choice is what is important.
Yeah, this is a great conversation too, and especially how, we in New Hampshire, but, as a society, are defining community as technology advances and things along those lines. And, hearing the responses that it's creating, it's allowing for more person-centered planning, and those outcomes are still in line with individuals' goals and support requests is great feedback to hear for sure. And thinking about how we leverage that moving forward, and also knowing what CMS's expectations are around home and community-based care and what their assurances are to each state that provides them, and how we ensure someone's not isolated, how we ensure there are safeguards in place, how we ensure that privacy expectations are upheld as well. And I mean, just food for thought as we have this conversation to get everyone's wheels turning for sure about what we, how we might address some of those questions from a CMS perspective as they were to ask us. And I agree, Becky, really, approaching this from the stance that this is leading to quality outcomes for sure, is I think how we would really be defining that and going over that with CMS. And Drew, any additional thoughts on that as well?
No, I want to go back to that comment, Becky, that you made about 80% of community versus 80% of somebody's community. So I think that's a really important statement. And I think before this pandemic, CMS would have said, no, you know, there are very confined boundaries of what community are from a federal waiver perspective. If there's any time to probably take that conversation to CMS, it's probably now. So I think the timing of this is really good. I think it's probably not just CPS services, but I think there are others that might fall into that bucket as well. But I do think that there is an opportunity here from how CMS has reflected on what they've approved and how they've defined services that we might be able to use as we start to think about services in New Hampshire that was not there in the past. So I wanted to kind of call that out. I wrote it down. I really like the way that you framed that. I do think that there's an opportunity to knock on the door of CMS and see if there's some leverage there.
Jessica, quick question, and this may be jumping ahead, but is there going to be a separate opportunity to look at new services going into the waiver? Because this was really looking at current services. I almost started just kind of adding new things at the bottom, but then I wasn't sure that was what this exercise was for. So
that's awesome, actually. Yes. So today, or this month's assignment, we're going to be looking at some peer state services. And we will have the opportunity to look at other services available and what those might look like within each of the waivers. And which for me, in my role, is very exciting. I really enjoy seeing how other states approach this as well. But also, you know, as we have these conversations, sometimes in going through services within other states, we see, you know, gee, they've been very thoughtful about this, as we would expect, but they're addressing, even within their service definition, some of the questions that we're posing to one another within this group. So yes, there will be definitely. And Drew, I'm sorry, additional thoughts on that as well?
No, I think that's exactly right. I mean, Sarah, you are right on target with where I think we were hoping to take the conversation. It was kind of, let's look at that baseline of what do we have, and then put that into context of what others are doing. And so this conversation about CPS, right? We might see like services that other states are doing that aren't exactly CPS, but might be enough of the shift or be able to achieve what this group has been identifying the interest to be around more flexibilities in what the service is provided. So I think that's what we wanted to do is really open that up and say, here's what's out there. And if something's not on that list that you've still been thinking about that you almost added to this list, that shouldn't stop it, right? I mean, we don't have to only select from the known menu. So I think this is that opportunity to really look at what is it that are the services that are probably being provided now, but having a structure and having definition and having rates behind would make it a lot easier to expand and to make it more of a statewide service. So I think you're right on track, and I think this is going to be a really exciting activity.
And I think to reference not only other states, but maybe waiver services within our own state that are just part of a different waiver. So like through the CFI waiver, you can get home delivered meals or skilled nurse visits. And would any of those make sense within the DD waiver, especially for folks maybe who are living a little bit more independently? So that's kind of what triggered it for me.
I think along those lines, and the conversation we just had about like even CPS during COVID and the change between COVID and staffing issues, right? We've all had to get really creative, and I'm just wondering if it'd be a worthy exercise, and maybe it's just me, of collecting examples of things that we're trying to do currently, because some of the things we're trying to do currently because of staffing and because of COVID aren't necessarily bad. They're new and creative and actually really good. And like what I'm finding, I can think of two different situations right now where the solution's in front of us, but the certification and billing mechanism are not. We keep running up against a wall there. And that maybe some of those things would help inform new services, to Sarah's point, and kind of where do we go from here? And maybe it's things that, you know, Drew can tell us from a federal level, or somebody can tell us that it was already available to us, or it needs to be available to us in the new waiver structure. I don't know, but I think some of those, sometimes having those concrete examples of the things we're trying to do could be helpful in designing, like, or looking at where things fit going forward.
I think that's a great idea. Rebecca, is there something that comes to mind immediately, just as an example?
Yeah, I just didn't want to go too far. I'll try to summarize it really quickly.
Yeah.
So, for example, we have an individual who actually lives in her own home. It's a home
Yep.
of your own for people. And she has needed increased supports. And we would hate for her to have to go to a 24/7 community residence.
Yep.
So she has somebody living with her who, again, she lives in her own home. It's her right. She has someone living with her that is just not going to meet the level. They don't want to be self-directed. They don't want to manage that for her. Everybody feels at this point that person needs to get paid to actually provide some services. And we were trying to do it under 521, but 521 says it has to be family. So the liaison saying you can't because you need to look at self-direction. Self-direction is just not an option for the person or the person in her life. Like we just keep, and so here's a great example, right? We don't want to put more residential in place than we need for this person. And there's no need to. She should be able to continue to live fairly independently in her own home. But we are running up against, and so that along with a couple situations where we know that a companion would be a better model than actual 24/7 residential supports. And that's not a BDS thing. I think I brought that up before, but I'd love for BDS to help us figure out how to get the companion arrangement back. That was a cost saving option that also provided more independence for an individual. You pick your own companion and you're not, again, pigeonholed into that 24/7 model. But these are the kind of people that we do end up overserving to an extent in residential because we just don't have any other option.
Those are great examples. I think that, yeah, definitely we want to move towards having that kind of flexibility. And that was always part of the discussion around what are the differences between the CFI waiver and the BDS and ABD waivers in terms of what people need and how we can build those in. I mean, I think that's a great place to have the conversation. Yeah.
I
It's
also very
where
much,
I find it.
oh,
Sorry.
sorry. Sarah, I actually was going to agree with you on some of the points that you made because, for example, we have adult day programs for seniors that some of our individuals would really, really benefit from being able to go to because sometimes what you say is someone gets to a point in life and they retire from, community participation services because that just doesn't work for them anymore and not what they want to do. But they would be so happy going to an adult day program with other seniors because they're seniors at that point too.
Yep.
Being able to participate in all of those activities, but there's no way to do that because the adult day is on a different waiver and is different. So it would be really nice, as Sarah mentioned, to sort of be able to mix and match because they are people who should also have access to some of those other services as well.
Well, and Renee, you know that I've always supported that because I think it clearly, and it goes to Rebecca's comment earlier, I think about how community gets defined for individuals and what inclusion really means. And particularly when we're looking at where those adult days are set. And I think there's a lot of possibilities in there, hopefully. And we may need to continue to advocate with CMS because I heard a conversation yesterday from a CMS person that made me cringe relative to settings rules and how that's going to be part of the new legislation relative to Build Back Better Act. I think we're going to need to advocate and seek some flexibility within that because we do have an aging population in New Hampshire that we need to look at very differently in terms of what their needs are. Yeah.
So Alicia, if you could please move the slide forward. I think I jumped ahead, so there's still some additional conversation topics that were on the next slide. There we go. So, I mean, we've really started jumping into this one. One of the comments that came up, and I'm sorry to go back to residential services, but around CPS and residential really is there a thought about breaking out personal care as its own service? And I think I saw that in a couple of comments in terms of, instead of, or in addition to maybe offering different services on different waivers, what does the group think at this point about maybe, say, having personal care broken out as a separate service in and of itself?
So would that be more like a home health kind of situation that you're thinking of, where someone just needs like personal care assistance in their home?
Yeah, I mean, the way the comment really read was, maybe should we look at breaking this out? So if someone were residing in advanced family care, or maybe living independently, but required a bit of personal care, especially in the independent living situation, to prevent them from needing, a higher level of residential service, if there were an option to continue living as independently or in as least restrictive of a setting as possible. That could be an option as well, where we're talking about what does the future look like, and what are the options in front of us as we look at other service options and how other states are approaching this, and other ways to, ensure that we're offering the right services for individuals.
Can I add just a little bit of context to this conversation as well? So personal care, personal support services. So as I think about CPS and some of the things that I've heard during this call around additional flexibility of a community-based support that's not necessarily as strictly a day service, but then also the flexibility to provide supports in a person's home. Personal care services can be used that way, and are used that way in a lot of states, right? It's a couple of challenges with that, though. It is typically a one-to-one service, and CMS typically requires it to be. You can get waivers for a 2-to-1, but really it's not as engaged, I think, as what this group is talking about with CPS. The other, just going to say it, this is probably the closest link service to EVV. And so as we're talking about it and as we're thinking about it, I think, you should just kind of know the positives. It's a very flexible service, and it does give you a lot of ability to meet somebody with where they are and what they want to be doing, and talk about volunteer activities. And I think a lot of really exciting stuff, but there are some limitations. I think that one-to-one component as a requirement, as well as a higher need for EVV. So for those not familiar, electronic visit verification out of the 21st Century Cures Act, which requires clock in, clock out for the service. And so it is a little bit more administratively burdensome, related to how that time is captured and how it's reported. So those I think are the trade-offs. So just wanted to kind of toss that in as this conversation's happening.
Thank you, Joe. So another component that we've touched upon slightly, but we can jump in here, it's reflected. So is telehealth was definitely called out as an important service modality to continue on. And we've built some of that into the current waiver, but what we're curious about, because we heard that through most of the responses actually, in at least one service or another, what services specifically would you like to see offered in a remote delivery option? Oh, hey, Pam.
Hi, I'm Pam Duchesne. I'm the Director of Case Management here at Community Partners. And let me take the hand down. Sorry. And one of the places, obviously, I'd like to see continued is in case management. What we found, and I think we've found in other services, there are people that need a lot of support. And sometimes when trying to connect with them, you're not able to get them all the time. What we have found in certain instances for some folks, it's worked out really well to be connecting with them through telehealth, through, whether it's Zoom meetings, whether it's, calls, whatever it is, that we want to make sure we have the flexibility. I'm not saying that we want, one or the other, but having a combination of both has worked out really well. I think throughout COVID, we have found that we've been able to keep in touch with people because of that. if we did not have that opportunity, then we wouldn't have been able to be, connect with people, ensuring that people were safe, ensuring that, if they needed something, that we could get things out to them. So I think that's one of the things I want to make sure that continues, and not looked at as doing it because it's easier. That's not I think what we found is it's more helpful, and it's not for everybody. We wouldn't use that for everybody. Again, it's like anything else, it should be used for specific individuals, what their situation is. It's been extremely useful.
Excellent. So it's a tool in person-centered planning, it sounds like. Now, does anybody else have any thoughts on which services specifically, or some ideas of how during you're utilizing appendix K flexibilities? We've talked a little bit about telehealth options and CPS, but for any of the other services?
Jessica, I would just add specialty services. I think especially in COVID, we utilized that a lot and it was very successful. So I would certainly consider that. In addition to CPS, which I think Renee touched on before, we were able to do many Zoom activities that were beneficial.
Okay. And then I think part of the discussion, and it's listed here on the slide as well, should virtual or remote supports have the same or different waiver definitions and provider requirements?
I think it depends on the service. Like, we've been using it a lot, to Jen's point about specialty services. We've been using it for our BCBA consults. I don't imagine the rate would be different for in-person or remote. It's still the same kind of clinical level of expertise that you're accessing. It's just been easier access for us to our BCBAs when you cut out the travel time that used to be needed to kind of get them. And they're still doing some in-home visits as needed, but a lot of kind of the team consult piece has been able to move to telehealth, and it's just flowing much more smoothly. And given capacity issues around BCBA services, it's been helpful.
Can I ask just a quick follow-up on this topic? Has anybody piloted or talked with any other agencies who have piloted a virtual residential service or a virtual day service? And thinking about day services like supported employment, I think there's some opportunities there, but just interested if anybody's aware of anything that's being piloted now that we might be able to take a look at, or if not, there are a few providers in other states that maybe would be willing to come in and talk with this group about what some of those additional options are as we're thinking about it related to staffing shortages and some of these flexibilities.
I know, this is Deborah from Farmsteads. I know of some programs out west, Texas, I think, that are using a lot of technology to provide supports for people. So from, whether it's cameras or alarms, various IT things. So I could connect with those people and see what they're doing.
We haven't pulled the trigger yet, but we're really very, very interested and close. We have a program where we have on one property, basically, it's technically two, but there's a house and there's 2 apartments. And the individuals in that program have wanted to step down or do something different for a long time. A lot of other challenges I won't get into. It's absolutely a program that's ripe for increasing the independence of the folks that live in the apartments, and using technology and having the staff be in the main house, and absolutely for staffing reasons. But it's another one of those win-wins where if we could get that going, we think it would really allow testing the independence and the step down level of the individuals in the apartments who think that they're ready to go live in their own apartment, but haven't been successful doing that. I think that as we try to understand how we can build that and how that works and how we can even get the money for the IT infrastructure to do that, it's something we're very interested in doing. I think it has a ton of potential for folks that we have traditionally overserved because there was no other residential option. It's a perfect program because there's no personal care actually involved with this program.
Okay. Yeah. Has anyone else heard of any pilots going on locally, regionally, nationwide? So this is definitely a conversation that's coming up on a national level quite a bit as well, and how we might be able to use technology to assist in allowing for more independence. Just as you've said, Becky, I think it's a similar model that we're seeing in various states, and there are a couple of states as well. Drew, I think they're referred to as technology first states that are really doing some kind of leading work in exploring a lot of this. And I don't have a very deep level of knowledge about how they're going about this, but technology first states, I think there are two.
Yeah, it's really it's an exciting model of just really diving in and kind of opening up the space for tech firms to come in and work specifically with DD providers to look at opportunities. So if anybody's interested in learning more about it or connecting with agencies in these states, Missouri and Ohio are the two most active. And I would say Missouri has focused it more around how providers leverage technology in services. Ohio has done a mix about allowing additional flexibilities in virtual supports for providers, but as a state has also invested heavily in technology and specifically around how DSPs access training. So I think they're really two good examples as we're having these conversations that have been doing this for a number of years, really invested. Missouri is also very deeply invested in charting the life course. And so, I think you see a really good blend about how do we support somebody holistically in their life, but then also leverage technology where it's the right service for them and the right support structure for them. So some really exciting examples there.
All right, Alicia, can you please move the slide forward? Okay, so this is broken down in percentages, the most frequent responses for each of the services. Let everyone kind of take a look. Please raise your hand, speak up if you have questions for the group, or if anything here surprises you, or if anything that you reviewed in the assignment surprised you or provided some aha moments, maybe.
So is it safe to assume that when we see CPS and see 42% were in favor of keeping, I mean, that's pretty low, because I would assume the majority were interested in changing, keep but change. I think that's
correct. Yes.
So it would seem that keep but change would be the more important data point across all of these as we move forward with our work.
Yeah, I do believe so. And what are those opportunities for change? Really looking at the feedback that we received from the group in terms of what that change might look like. And then as we delve into what some of our peer states are doing, what other options are out there, is there a service that more appropriately captures what we're all thinking the future of the services would look like, or is there an ability to update or change the current service definition? So what we'd be looking to do with this group would be to either, exactly as the group has provided, either use the same components within the service or revise them, and the revised service definition would be drafted and proposed from this group. Okay, is anyone still going through the data, or let me know? If not, I think, Alicia, we're all set to move to the next slide, please. Okay, so any last thoughts on the service mapping assignment or any of the information that we went over to before we move into our next topic for discussion? All right, thank you all. That was really awesome feedback, both in the assignments and for the discussion that we've had. Okay, so now we are going to pivot just a bit and start talking, pivot a little bit, but really part of building out all of our service definitions also requires us adding into the waiver provider qualifications. So it's a great time to start talking about DSP training opportunities and have a discussion. So hearing the need to continue to build the workforce capacity, we're really interested in exploring more defined training requirements. And we did hear that throughout the responses as well. Either more training requirements, specific training, really looking at what we have and how it can be updated. We think there are several benefits to this approach, including better standardization across the state in our workforce training, stronger capacity for the area agencies in the private vendors to develop purchasing cooperatives to purchase high quality training at lower prices, develop a baseline for establishing DSP credentialing structures that can promote DSP development and longevity in rate setting, and better statewide portability of training and skill sets for DSPs and reducing staff downtime during that. So in hearing these, what are the group's thoughts about this approach? And are there any specific training programs that you'd recommend or that you've heard of and would like additional information about how to evaluate this approach? Hi, Krista.
Hi, I just want to share that the DD Council has a work group that's specifically looking at the DSP issue. And part of that is looking at like DSP credentialing. We have an interest in this, and we've been looking at what different states are doing in their curriculum. So there's a high interest in that. And so I think that our group sees that that there's value in different programs that different states have done. The NADSP curriculum, I think there's some value in that. There's also some limitations. And in looking at what different states have done, we also feel that there are some outliers that are often not included in the trainings. And so as New Hampshire looks at the training for DSPs, we want to be sure to include those people. So, people that are not, that don't use verbal language, we feel like those are often left out of trainings. And people with other high level needs, we feel like that's going to be really important to include in training.
I do think that the attempt was made years ago in trying to do this with, the work that was done with the CISNY group and bringing Relias into the picture, creating that CISNY crosswalk that was, seen as being definitely the needed trainings for direct support professionals to have in order to be able to do their job well. And it, they are closely in line with, the regulatory trainings that we have on certification. So I think that was kind of like the initial step years ago, but then it hasn't been looked at again, and it hasn't been like brushed up or, really kind of explored more deeply, whether that's still the right platform, whether other things need to be added. I mean, I know that we've added a lot of trainings on top of the CISNY crosswalk just because we didn't feel like it was complete enough, especially in certain situations and certain types of programming. So I do like the purchasing power and being able to, maybe kind of collaborate and find some good trainings But, I think that this was we tried to do this years ago, and now it's just gotten to the point where it needs to be looked at again and really, updated.
I think that.
Can I ask a follow up to that? Oh, sorry, go ahead.
I was just gonna say, I think you'd be hard pressed to find anybody who didn't agree that more training. I know that Relias was a great way to kind of equalize, and I agree with Renee, it's very much the regulatory training. It's just really, I can't understate enough, obviously. It's very frustrating. We're seeing it with the workforce crisis. We're seeing it with who we're hiring. We're seeing it in quality and complaints. We know that we need to do better, but it's really hard to get through that when you just don't have staff. And then you look at managers and say you want to do more training with frontline staff, and they look at you like you're nuts. But I think the bigger picture is that we have to tie some sort of certification level and approach to a career has got to be tied to wage reform. The two have to go hand in hand, and so that we're bringing up the level and training and expertise far beyond regulatory, right? Again, the folks that are working with higher behavioral acuities and just everything that we're dealing with. But I don't know how. If in a perfect world, bring on the training. We need it, but we just don't have time.
Becky, I echo that. I think we're seeing more and more people come in with more complex behavioral medical needs, and there just isn't that training, like Renee said, in the Relias curriculum. So I think we're all individualizing our approach, but to have something standardized makes sense. So we fully support that.
So just as a quick follow-up to this, just make sure I'm hearing it right. So Relias is very good at regulatory training, right? I mean, they do that in a lot of states. Thinking about the DSP workforce and thinking about some of the challenges with getting DSPs through training, is the structure of how people are accessing Relias training working, right? It's just a matter of getting the right training into the module, or is it also looking at a different mechanism or a different kind of modality for offering training as well? I guess is the question. Because there are options on both sides of that, right? If it's the content, there are other training venues that do kind of more holistic content as well as regulatory content that I think we can talk about and we can take a look at. If it's also changing the mechanism in which DSPs are being trained, so going away from text-heavy training, for example, or more academic training into applied training, where you're seeing videos of DSPs doing work and talking about how to actually complete tasks, I think that would be helpful to better understand, is that part of this change that we want to see as well, is not just the content, but also the modality.
Yes, the answer is yes. I mean, it's yes to both.
Okay.
So I think that we can always improve and tweak Relias, and I think that's a pretty solid platform, like you said, that we can continue to use. I think it's an important platform for the quick onboarding, and but I think that our DSPs have been begging us for in-person. Before COVID hit, we did our first really big 2-day shutdown services, DSP training than we'd done in years, and we got amazing feedback. They are dying and starving for that in-person training and that on-the-job training as well. I think it's not any one thing, it's all of the above.
And to your point before, Remy, I saw, so there were a lot of, I think everybody's head nodding, talking about DSP credentialing and tying to payment reform. This is kind of that first step, because typically in a credentialing structure, we have to start with that base of how are people being trained? How do we build core understanding and expectations? And so, really kind of focusing in on this, I think gives it an easier step to the next, right? And so if we can get common understanding and expectations around this training structure, then I think getting to a credential is not easy, but is very doable. And I think that's the hope here as well, is to get this baseline covered first.
I'm just going to throw out there that there's another training system, Open Futures Learning, I believe it's called, that seems very interesting. And they focus on the DSP and the individual they're supporting going through the trainings together, which I think is interesting.
Deborah, could you repeat that?
it's like, I mean, to Ben's credit, right? He's built a really good training structure there, and very different than what we had seen through Relias and through College of Direct Support and some of those kind of more standard historical trainings. And I think he's sparked, and that's, Deborah, I'm really glad you raised this, because I want to bring some examples to this group as we continue this conversation. He sparked interest in other people to think about training differently as well. And so there's now another organization in Arizona who works with Ben and with Open Future Learning that is doing 30-second videos about DSP tasks, right? So again, this idea of having ongoing job support and having ongoing examples of how to do tasks when you go in and you're actually working in a home for the first time is something that we didn't have in the past. And so Open Future has really changed, I think, the way that we're thinking about training, and now we're seeing some really exciting add-ons to that structure come into place. And so that's why I was hinting at this idea around modality. Is I think what we see in Open Future is very different structurally in the approach from some of the traditional trainings, which is good and is exciting, but wanted to make sure that this group is also interested in that type of change as well.
I think if they are able to develop trainings and have trainings that staff can attend with individuals, that's a win-win situation, because freeing up staff to be able to go to training, we all know, is very, very difficult. We have to do it, but it is hard. We've developed a lot of a new training calendar that has been really helpful, and a lot of the trainings the staff can attend with individuals, and it's made a huge difference in participation. And some of it was just tweaking trainings that we had so that it would be applicable, so that the individuals could attend as well. But that definitely is a great concept. So I'm interested in hearing more about that, because I think that that is a way to, increase participation in trainings.
Definitely, and flexibility in how and when it's accessed as well seems to be one of the key points that's been brought up. It's a really interesting training program if you have the ability. I think there are some snippets on YouTube as well that go through it. And again, we touched upon it before and said, what is our definition of community, especially looking at technology and where we are as a group collectively across the country. And it's interesting to see how Open Futures Learning has included that and had their modality of training as well.
I also just want to reiterate Becky's point about having a career ladder for DSPs. So thinking about, what that looks like, making sure the pay is, something that is a livable wage, as well as figuring out benefits. I think that's been one of the biggest barriers, especially if you have individuals that may not need, a full 40 hours of support. Like, how do we get creative and allow ways to figure out, it coming out? And I know there's a lot more to that than, just like, two people equals 40 hours in benefits. Like, it's what budget does it come out of? What does the rate look like? What does that mean? But really getting creative and trying to figure out those things and make it, workable for families, as well as, the people that support those that we love.
I would just like to share a concern that I have as we're talking about, pairing the training of DSPs with a recipient, that we don't place a burden on the recipient or family members for the training, that we're not placing an additional burden on them, and just to kind of keep that in mind.
Absolutely. I think there are certain individuals being supported who would enjoy and benefit from sitting through those trainings with their staff, specifically something like client rights training. But there are other individuals for whom it probably is not appropriate. So.
Thank you, Krista and Deb. I think those are really important points as well, and how we approach that. Just as you've said, Deb, certain aspects, definitely ensuring that individuals, if they want to hear and see what is the training, what is the, what are the goals of the work that might be done, and what might it look like? But Krista, to your point as well, ensuring that it's not somehow placed back on the individual or family. So Elisa, can you please advance the slide? So as we move forward this next, over this next month, we'll be pulling together some research about DSP training requirements nationally. We'll start with existing research to leverage the expertise of the DD community, and we'll supplement the research with targeted peer state research. And we'll focus on questions like, things that we've brought up already. What are the main commonalities and training requirements across the states? And what are the main differences in training requirements? Which states implement a credentialing system? What platforms and modules are states and provider networks using? And how do expectation for training and requirements vary depending on what services are offered? And we'll work to make this information comparable across states and report back to the group at our meeting next month. Any requested changes to the focus areas or additional, I know we've shared several things today already, but in this discussion, but other areas for us to focus on over the next month while we're gathering that information? Okay. Thank you. All right, Melissa, can you please switch to the next slide? So now next steps. So we've hinted about the homework assignment a few times, and should we, let's read it. So this assignment will be due back on the 29th, it's a Monday. We'll ask that it be sent to our BDS Waiver Structure Workgroup email. Right now, what we're going to be looking at this month is peer state services, services offered in peer states. I believe it's Connecticut, Massachusetts, Missouri, and looking even within New Hampshire. And what are, what are some opportunities that are out there? What do these look like? Anything that looks really interesting to folks? We've heard people through the activity from this past month and even in this conversation comment around, gee, maybe the way we have this service titled, maybe there's another opportunity out there. So definitely a great opportunity for us to dive into that and see if there's anything out there we're all interested in. Can we please bring up the assignment or the exercise?
Sure. Give me just a second to navigate there. Okay. It's set up in a similar way to the homework that you all completed last month. We have instructions on the first tab, and we ask that you again make choices in 2 columns and add notes into a third. The difference with this workbook is that we've categorized services for your review into 4 different groupings. So you have 4 tabs to provide responses on. One is residential, one is day service, one is family, and one is other. Each of these tabs provides supporting information to the right. If there's a 1 here, that means that this service, so each service is in a row again. I know that I'm zoomed out. Let me zoom in a little bit. So this 1 shows you what waiver that particular service is included in, and some services are included in waivers from multiple states. Towards the back of the workbook, there's an all service definitions tab that will help you familiarize yourself with the services across all of these waivers before you ultimately make your selections. There is a lot of information to review here, so thank you in advance for doing this work over the next month. And I hope that this workbook allows you to do it more effectively. If you're curious about the waivers themselves, then there's also information included here about those summarized by state. So like Jess said, Connecticut, Massachusetts, Missouri, and New Hampshire. And I know that that was a lot of information to take in. So the specifics of each tab are included in the guidance and instructions. Are there any questions or comments about what I just went over?
So what are we supposed to do?
Good question. So for each service, you're identifying if you think that it's appropriate for future use. So basically, like if you want to know more about it, and just like you did before, you enter here, explore, do not explore, instead of keep, do not change. And then once you've decided if you're interested in a service or not, you identify which waiver you think it's most appropriate for, or if you think it's most appropriate for both. And then again, there's a space for you to add notes. Okay. And if there are questions,
oh yeah, sorry, Lisa. I was just gonna say from a navigatability perspective, it might be easier if folks are kind of reading through the different service definitions to mark the ones you think are worth exploring, and then can pretty easily just say do not explore to everything else. And so it's a lot of information. It is very dense. Like Alicia said, thank you for doing this. I think this is going to be a really important input into the process. And so if folks feel like it's taking longer than, I think we're asking for them back at the end of November. If it doesn't feel like that's achievable, just sending an email to the waiver work group email, just so we kind of have a sense to make sure that we're able to kind of capture this, and we can work with Jess and Sandy and Nancy if we need to extend this out. But it's a lot of information to go through, but it's really important to get a sense of what types of services might be worth adding or taking some of these and making modifications. So
I'm jealous of Jen, who already works in other states.
So just for my own information, Alicia, so at the end of the webinar, will this workbook be sent to all of the members, or how does this work?
I'll send it out. Yes, so you'll get the spreadsheet in an email from the email address here, the waiver work group email.
Perfect. Thanks. Yep.
Okay.
Thank you, Alicia.
Mm-hmm.
So any other questions from the group on any of the topics we've discussed today, the assignment for this month? Anything else that anyone would like to share? All right, well, I think with that, we may be able to end a little bit early, and I thank you all and value everybody's input and participation in this group. I hope you have a great few weeks, and we will reconvene next month. Thank you all. Have a great day.
Thank you.
Take care, everyone.